This case belong to a woman, 37 years old, regular periods, previous screening, pap test negative. And we saw layer of epithelial elements, with visible cytoplasm, neutrophil phagocytosis, and variable-sized nuclei with evident nucleoli. So we were really with some doubt. It's clear for you? It's not clear for you. It was really not clear also for me. So don't worry. We were in the same side. I was not clear, and I was in doubt. Negative, can I say for sure negative? To be negative, it means I see the patients in 3 years. It's too much. And low-grade seal, high-grade seal was not completely sure, but something it was wrong. I have a good feeling with the clinicians because we talk about every day, and I have to say that often the clinician call what I have to do. So sometimes I ask me, say, I don't have understood very well these cases. What we will do? And he decide, okay, I will have a colposcopy. Okay, let's say colposcopy. So perhaps we have also some other information. But looking at mild increase of nuclei size, nucleocytoplasmic ratio not alterated, visible nuclei, all these characteristics, they should bring to the right diagnosis. They are enough to reach the right diagnosis. But, okay, what did the colposcopist say? Okay, I had a colposcopy, but I was there, I had also a biopsy. Okay, so we can go, we can see what it was. So, with the biopsy, and the biopsy was a repair. So the repair is something very important, because if I see to repair in the literature, in 400 cases, we see that 15% they were misunderstood and they did false positive. So it means that we have some problem with the repair. And why we have some problem? Because this is the repair show the typical feature. But how many times do you see the repair in this way? This is a picture, okay, but it's very rare that we found the repair in this way. The repair, look, this, two. There are two different things. they look about the same, but they are completely different. Think, what is? Here is the repair. There is low-grade seal. So sometimes the repair can also mimic the low-grade seal. You have to pay attention. So the repair change its aspect. Look at this. They look a little bit similar at the first. They look similar. But if I see, this is high-grade seal, the other is a repair. So sometimes can mimic also, the repair can mimic also an high-grade seal. Or this. Of course, they are different, but if you don't pay attention, you can also think they are the same. It's completely different. Repair and squamous carcinoma. Or also both. They could be about a little bit the same. Repair endocervical adenocarcinoma. So, what I would like to show, that the repair often can mimic also other lesions, can mimic a low-grade seal, high-grade seal, can mimic a squamous carcinoma, can mimic also in adenocarcinoma. So, when you are not sure about a lesion, you should think also at the repair in differential diagnosis. Put in mind, exists also the repair. Okay? Thank you.
So the next case will be a very quick case, very simple case. So don't worry, everybody's going to get the right diagnosis. And not that. Next one, please. Yeah, okay. Okay, that one. So 32 years, the woman she's HPV positive. So please keep it in mind. And at low magnification, you already see that, and that, and that. And if you look at higher magnification, you find that. And if you move to another part of the slide, you find that. I hear, aha. Somewhere. You have seen something, maybe? Okay. So now, I would like to discuss very briefly the diagnosis of this woman. So she has not a cancer. You agree with me? Okay. So we are speaking about between negative, ascus, low cell, maybe somebody's going to call it SKH, high seal, I do not know. So who is going to call it negative? Nobody? 1, maybe 2, 3, 4. Who is going? 5. Who is going to call it ascus? The majority. 1, 2, 3, 4, and so on. Who is going to call it low cell? Nobody? Nobody's going to call it low cell. So that's a really quick case. You shouldn't forget that the woman is HPV positive. Yeah, you remember that. There's a primary screening with, or could be your first primary HPV screening case. So what's important to remember when we speak about ascus, about low cell in HPV positive women, is that if you look to the positive predictive value, that means the probability to find a high-grade lesion in the follow-up, that means a clinically important lesion, a SIAN 2 or more in the follow-up in a histology of this woman, that the positive predictive value of a ASCOS that is HPV positive is even higher compared with the positive predictive value of a low cell. So that means that actually, from a statistical point of view, most of you say ASCOS. From a statistical point of view, a HPV positive ASCOS and a low cell are almost equivalent. Actually, the HPV positive ASCOS has a higher risk, marginal higher risk, to develop a high-grade lesion in the follow-up than a low cell. So actually, that is the point. This lesion and this lesion, if that lesion is HPV positive, are equivalent. So that is there's a very different attitude in different countries how to manage these cases. In Italy, for example, and not only in Italy, if we have a case that fulfills the criteria of an ASCOS and our cells were actually fulfilling the ASCOS criteria, they are going to call these cases no more ASCOS, but low cell, and the ASCOS category is almost will be also deleted from the usual routine cytology in HPV positive cases. So if you have changes that are ASCOS-like, we are going to call it directly low cell because of the high positive predictive value. If they don't fulfill the ASCOS criteria cytologically, we are going to call it negative because this woman anyway will come after 12 months to a control cytology. So in that case, actually, the correct diagnosis will be low cell in spite of a picture that because of the nuclear changes, that may be changes consistent with the low cell, and the coexistence of candida of a mycosis, which makes the diagnosis more morphologically more uncertain and should be and could be consistent with an ASCOS. At the end of the day, we are going to call that case low cell. Do you have questions? Because this is quite a difficult point, or a matter of discussion in this moment in Europe, how to call these cases. Do you agree with me?
Yes.
Do you agree with me? We don't do ASCOS with candida. Okay, and when you have a high HPV positive case, then it's no. But maybe you will have it in short time.
If you see something like this,
Yeah.
you just say
Okay. Okay.
you don't ask.
You don't call it that. So in that case, it's very simple. Okay, thank you.
Sì. We have other time? Do you wish another case?
Yes.
Yes? Okay. Number 3. It's a woman, 44 years old, regular periods, non-previous pap test. So it's the first pap test she had. We have crowded clusters. it's not so difficult, these cases, but we can think a little bit about for one reason. Atypical elements with enlarged and hyperchromatic nuclei, and this is what we see. It's quite easy to make diagnosis, and I don't also to ask, because I'm sure that everybody have understood. But why I present this case? For one reason. Because, of course, here we have to choose which kind of diagnosis, and we saw basal and parabasal atypical cells, centrally located nuclei. So centrally located nuclei give us that they are squamous elements, because if is located on the back, they are more glandular lesion, and also the cytoplasm. We don't have any problem, and we said high-grade seal. Which is the problem of these cases? That she undergo to colposcopy, and the clinicians saw just a polyp, and she said, I don't see anything. I don't see anything. So he had the biopsy of the polyp, and we say, yes, it's a polyp, but all the time, and I'm lucky, because in all the region, our is just one institution of the pathology. So we see all the cytology and all the pathology. So when I have some discordance, I write is negative, but 2 weeks ago I made the diagnosis at the women, and I wrote, but 2 weeks ago I find a high-grade seal. So please go on. And how you have to do for the management? When the cytology is positive and the histology is negative, the first thing that you have to see to confirm the lesion. So you take the slide, you see again, and you can perhaps have a better diagnosis, because you know that you have a biopsy negative. But if you are sure, you have to confirm the diagnosis, you can talk with the gynecologist, and we arrive at the excisional biopsy, and excisional biopsies has to be performed. And for this reason, I insist that we should have a good relationship with the clinicians, and the clinicians have to believe in you. And I've worked in the field of the gynecology for more than 40 years. So I know very well all the gynecologists. If I say there is a lesion, they believe in me and they go on. And this is important, to have this kind of relationship. And when I had a peer review and I said there is a high-grade lesion, they undergo to the conization, and we could see that it was the lesion. But the lesion was high in the channel. So remember that often the high-grade lesion are often located in the upper zone of the cervix. So sometimes the gynecologist with the colposcopy, they are not able to see the lesion. But if we are sure, we have to insist and go on and say, please go on, because we see the lesion, we are sure, and we have to find this lesion. I think this will be the best, because now we have the lunch. So thank you very much, and at the next time.